impact on management. So today we are talking about hepatitis B virus only, and we are talking about general treatment and the treatment of special population. And I want to concentrate on the recent WHO guidelines because they are relevant to Sudan and South Sudan and other areas with low resources. How can I go? So as Hala mentioned last time, hepatitis B is a really big problem globally, but it's mostly a big problem in Africa, Southeast Asia, and Western Pacific. And I think as juniors in Sudan and South Sudan, you probably know this. There's been a big move worldwide to try to eliminate viral hepatitis as a public health, both B and C, by 2030. We started this in Sudan as a strategy and a guideline, but unfortunately with the war, things have mostly stopped, but hopefully things can pick up again. We have a lot of challenges in management of hepatitis B. Most people don't know if they are positive or not. Even people who know that they have the virus are hampered by social stigma. They have poor access to care. Even if they have care around, most of the investigations and treatment are unaffordable to a lot of patients. There are a lot of misconceptions and a lot of ignorance, even among healthcare professionals, about hepatitis B in general, about the mode of transmission, who needs treatment, how to deal with these patients. And of course, we have the issue of scarification, cupping, herbal medicine, cauterization, all things that worsen liver disease and may lead to dissemination of the infection itself. Just to explain how we treat. So the virus is a DNA virus. So what happens is when you get the infection, the virus enters into the liver cells and uncoats its DNA, and it forms a circular DNA within the nucleus of the hepatocytes. So it's very difficult to get rid of the virus once you get the infection. And this is important. Why? Because when in Sudan, for example, we were practicing, people come to us saying, please give us treatment. We want to be negative so that we can get married or work or travel to Saudi Arabia, for example. But it's very difficult to get rid of the hepatitis B because its DNA stays in the cells as circular DNA. And although there has been a lot of progress in management and so on, but until now, there is no specific medicine that gets rid of the circular DNA from the hepatocytes themselves. So why do we treat? We treat for specific goals. So we treat why? Because if we don't treat, the patient who has the virus can have inflammation of the liver, can develop liver cirrhosis and hepatocellular carcinoma. So our main goal of treatment is to improve survival by preventing progression of liver disease, as well as preventing complications like hepatocellular carcinoma. These are in patients who are positive. There are other goals. For example, we want to decrease transmission because in our part of the world, a large number of new infections comes from mothers to children. Unlike in the other parts of the world where it's mainly sexual, in our part of the world, it's mostly transmission from mother to child. So we want to decrease this transmission. We want to prevent reactivation in people who are having chemotherapy or immunotherapy and so on. And we want also to treat extrahepatic manifestations. So that's the main goal. So as you can see, the goal is not to just clear the virus. If we manage to clear the virus, that's even better. There are several publications, several guidelines, American, European, and so on. The last guideline, which I think is very relevant to our part of the world, is the WHO guidelines, which were published in March 2024. And the good thing about these guidelines are they are really focused on how to manage patients with hepatitis B infection in low resource areas. So like if you don't have possibility to do FibroScan, for example, if you can't do the DNA and so on. So it broadens the simplifies treatment decisions, broadens the degree who is to be treated. So because a lot of people get really confused about who to treat and not to treat. This is it in general. I don't want you to read this. The guidelines are online. You can easily access them. This is easily seen and printed from anywhere, but I'm going to highlight it in slides. When you are approached with a patient who is B, so to get, how do you manage hepatitis B? So hepatitis B, first of all, you need to find the cases, okay? So in parts of the world where hepatitis B is highly prevalent, like for example, in Sudan or South Sudan or East in the Asian area, you need to screen. So you will never get the cases unless you screen. Ideally, you should screen all the population. So anyone coming into service for a test should be screened for hepatitis B surface antigen. If this is not possible, then there should be a way to screen high-risk population. You screen blood donors because they can transmit the infection. You screen health professionals. You screen people with chronic diseases like chronic renal failure, diabetics, HIV patients, tuberculosis patients. Even in Sudan, we used to screen patients with bilharzia periportal fibrosis because they have already one liver disease and they are at risk of acquiring the infection from blood transfusions. So we screen. Once you get a patient who is negative, because we are in a high prevalence area, you should vaccinate. Any negative patient should be vaccinated, any negative person. And people who are positive need to be linked to care. What do I mean by linked to care? They have to be seen somewhere. Primary care, secondary care, tertiary care, wherever is available, they should be linked to care. And the idea to be linked to care is to check their history, see if they have family history of HCC or liver cirrhosis. Do they have symptoms? Are they married? They have kids? What do they do? What's their profession? And to see if they are already cirrhotic. Do they have HCC? Are they having portal hypertension and so on? So the first assessment is important, okay? And the first assessment is not only to take history and do clinical examination. The first assessment also is for counseling, which is the most important thing in management of hepatitis B patients. As I said, there's a lot of misconceptions. There's a lot of misunderstanding. So you need to sit down with them. You need to explain what the virus is, what to expect from doctors, how they can modify their life to prevent transmission. And this is important because we are in part of the world where we share razors. Young ladies share razors for their eyebrows, for example. They share shaving equipment. They share nail clippers and so on. So they have to be educated with the risks of transmission to others. They have to understand that their contacts need to be screened and vaccinated. They have to understand that even if they are not for treatment, they will need lifelong monitoring. And if they need treatment might need to be lifelong. And this has impact financially, of course, because some patients have to pay for their treatment. They have to pay for their investigations. And also to counsel them to avoid harmful behavior like excess alcohol intake or scarification or use of herbal medicine. So the first visit is very important as education for them. So this is also in the guidelines by the WHO. So this is important. You do the first workup, which is checking their liver function, checking if they have renal failure, diabetic, checking for markers. And this has been said by Hala probably last session. And we need to check if they are E positive or E negative, if possible to check their DNA. All these things help us in decisions of treatment, okay? You need to assess for liver fibrosis or cirrhosis. This can be clinical. So clinically, you can find the patient to have signs of chronic liver disease, splenomegaly, ascites, or lymphedema, ultrasound that shows that there is liver cirrhosis or portal hypertension and so on. So it could be clinical or simply by an ultrasound that you can detect cirrhosis. Sometimes you need to use scores, which I will mention in a while. And if you have access to FibroScan, this helps. FibroScans are machines that measure liver scarring and it's like an ultrasound, and it gives you readings which put the patient into a specific score. So F0 is no scarring, F1 is mild scarring, F2, from F2 and above, that's significant scarring, F4 is liver cirrhosis. If the patient clinically and by investigations is cirrhotic, you need also to do a baseline alpha-fetoprotein because they are at risk of hepatic carcinoma, and you need to do endoscopy to exclude viruses. So this is the basic, simple initial workup of patients with hepatitis B infection. Okay. The scores that are used, the common ones are for any liver disease are the APRI score and the FIB-4. They use simple blood tests, which are the liver enzymes, platelet count, okay? You don't need to memorize the formula. These are links, but if you can download MedCalc, which I'm putting down here. So I think there's an app for it, and you can just put the patient AST and the platelet count, and you get the APRI score. So it's easy to get APRI score for your patient. And this helps, as you will see, in decision of treatment. So previously, people used to take liver biopsies to say that the patient has fibrosis or cirrhosis and so on, but now we don't. So according to the WHO guidelines, any patient, adult or adolescent that is more than 12 years of age who has chronic hepatitis B could be eligible for treatment if they have liver fibrosis. So if they have liver fibrosis or cirrhosis, you need to treat, okay, regardless of their ALT, regardless of the DNA, all right? How do you say that they have liver fibrosis? Either clinical, as I said, or you can calculate the APRI score if you have a score of more than 0.5, or if you do FibroScan and the readings are more than 7, which is more than F2. So for these patients, you need to start treatment. All patients who have co-infection, meaning they are C positive, HIV positive, hepatitis D positive, need to be started on treatment. And I wanted to elaborate more a bit here because patients with hepatitis C viral infection are for treatment now. Any patient with hepatitis C viral infection who is antibody positive, PCR positive is for treatment. And treatment now is by oral medication called DAAs or direct acting antivirals. These medications reactivate hepatitis B. So that's why any patient who is C positive, since they are going to have treatment, they should be started on hepatitis B infection. Haile is joining us. He's from Ethiopia. He's one of the people who were involved. He's in the waiting room, I think, who was involved in the writing of these guidelines. Welcome, Haile. So I was saying that all co-infection, HIV is easy because HIV medications already, most of them have treatment which can treat hepatitis B. So if you have HIV and hepatitis B, the risk of liver cirrhosis is higher, the risk of complications are higher, the risk of developing progression to cirrhosis and HCC is higher. So any patient who is HIV positive and B positive should be treated for hepatitis B. And I'll mention a bit more about D later on. Who else? Any patient who has family history of hepatitis B, liver cirrhosis, or HCC is for treatment. Why? Because we found even in clinical practice that it comes in families and they tend to get hepatic carcinoma really young. So any patient with family history of hepatitis B, cirrhosis, or HCC should be for treatment regardless of their ALT or DNA. And of course, on any patient on immunosuppressive therapy, because once you start immunosuppressive therapy or they are on long-term steroids, they will be they will reactivate and they will get active disease, high DNA, and the higher the DNA, the higher the risk of complications. And this is recent as well. All patients with comorbidities, MASLD is the new, or MAFLD is people who have metabolic associated fatty liver disease because they are at high risk of liver cirrhosis and fibrosis. If they are B positive, they can be treated even if they have normal ALT and DNA. And last is all patients with extrahepatic manifestations. Hepatitis B viral infection, they can have arthritis, glomerulonephritis, vasculitis as extrahepatic manifestations. And if they do have this, they should be treated. So this group of patients, they need treatment and they are treated regardless of their ALT and DNA. However, if you do have an access to do DNA, and you find that the patient has high ALT and high DNA, more than 2,000, again, these patients are for treatment, okay? Even if they are not having family history of HCC or extra hepatic manifestations and so on, or co-infection, all right? And here I have to mention that ALT level, the normal ALT is 30 for males and 19 for females, okay? It's not, so the labs can give you sometimes higher readings, but this is like most international societies have agreed that this is the normal, should be considered normal. So any ALT more than 30 or any ALT in males and any ALT more than 19 in females should be considered abnormal. What happens if you have DNA not available and the patient has no family history or co-infection and so on? You may still consider treatment if you have followed the patient for 1 year, for example, and they have persistently elevated ALT. Okay, so if you have at least 2 readings which are high within 6 to 12 months, then you may consider in a high endemic area who is positive, you may consider treatment. Putting in mind that there are other causes that can cause high ALT. For example, if the patient has fatty liver disease or autoimmune liver disease or excess alcohol. So you have to be mindful of other causes. If the patient is not meeting any of the criteria and you've decided you are not going to treat this patient, you still need to monitor these patients by ALT, APRI-score or FibroScan, and if available DNA at least once a year. People who you put on treatment, also you need to monitor them at least once a year. Okay. This is not mentioned in these guidelines, but you have to remember that sometimes you need to treat people who are surface negative, but core positive if they are receiving rituximab, which is an immunosuppressive therapy, or stem cell transplant. So any patient receiving stem cell transplant or rituximab, even if they are surface antigen negative, but if they are core positive, they are still for treatment. And you continue to start either with or before treatment, and then you have to continue 12 to 18 months post end of treatment, especially with the rituximab, because of the high risk of reactivation. Okay, the drugs used are 2, entecavir and tenofovir. So tenofovir, there are 2 types, the TDF or dipofoxyl fumarate is 300 milligrams, and TAF or tenofovir alafenamide. And so tenofovir usually is, I think, cheaper than entecavir, but it's according to the availability. Okay, TAF is not usually used commonly unless the patient is at risk of osteoporosis or has renal impairment. TAF is only a prodrug of TDF. Okay, and the difference between, for entecavir, we use the 0.5 milligram, unless if the patient has decompensated liver cirrhosis, and then we usually use the 1 milligram. Okay. For females in childbearing age or pregnant ladies, entecavir is not indicated, is a category C. So the drug of choice for females in the childbearing age or pregnant ladies is tenofovir. The new guidelines have stated that if these are not available and you have an HIV program where part of the medications available for HIV are tenofovir lamivudine or tenofovir emtricitabine, you can use them for hepatitis B instead if you don't have access to tenofovir or entecavir, which is really helpful because most of the drugs are available for HIV through the programs. What is the ultimate goal? The ultimate goal is usually, as I said before, you can't get rid of the virus completely, but we want to normalize ALT in people who have active inflammation. We want to achieve undetectable DNA level. So it would be helpful if you could check initially and after receiving some treatment, And in people who are e antigen positive, we want to see seroconversion, meaning they become e antigen negative and they develop antibody. The best is to get surface antigen loss, plus or minus. So if you get surface antigen loss, that's the best you can get, but it's very rare to get this. And if you get seroconversion, meaning negative antigen with a positive antibody, this is even better. At the end of the day, we want to prevent progression, if possible, improve fibrosis and cirrhosis, which can happen if they respond, and normalize ALT. And of course, as I said before, this will decrease risk of transmission. When do you stop? So you stop 1 year after getting surface antigen loss. So if you are lucky and you get surface antigen loss, you need to continue 1 year after surface antigen loss and then consider stopping. But as I said, this usually occurs very rarely. In people who are e antigen positive who develop seroconversion, meaning they become e antigen negative, still again, you continue 1 year and then you can consider stopping. At the end of the day, even people you stop treatment, as I said before, the DNA, the circular DNA still is present inside the hepatocytes, and they do have a risk of reactivation. And how do you know it reactivated? Either you get high liver enzymes, or the surface antigen appears again, or the DNA becomes detectable after becoming undetectable. People who have liver cirrhosis, you don't stop, because if they reactivate, they decompensate, and then the prognosis is worse. Okay. So we had a poll. I'm not sure, should we do the poll first and then continue?
Yes, of course, we can launch the poll now. Just a second.
Just try to answer what you know.
Make sure that you answer all the questions, guys, so that you can submit your answer.
Someone had a question.
Yeah.
Okay.
You want me to answer now?
Thank you both for nice lecture. My question is that if the patient has stopped entecavir, for example, after 1 year of treatment, and then she developed end-stage renal disease and is eligible for a renal transplant and need for long-term immunosuppressive therapy. Are we starting the immunosuppressive therapy or not? Thank you.
No, you need to put them back on treatment as long as they are surface antigen positive. So if the patient is surface, I'm going to speak about the special populations, but any patient who is going for immunosuppressive therapy and they are surface antigen positive should be on treatment. If the patient is already on dialysis, for example, or still not transplanted, still has renal impairment, there are specific dose schedules. So you can start them on entecavir, but according to the eGFR. All right. They can also have TDF, but also according to the eGFR. Okay, so they may be taking, for example, 1 entecavir a week. but they still need to be on treatment. We don't know who answered, so you can answer. You can get them all wrong, it's fine. If anyone has a question anytime, it's okay as well.
So,
Malal?
Dr. Salma, do you want to answer the question during the presentation, or it's
Yeah.
better to have them collected at the end of the session, as you see appropriate?
Is that finished now? Can we see what they did?
Yes, I think we can end the poll now.
Yeah. How do I know the results?
Are they reflected onto your screen, Dr. Salma?
Oh yeah. So yeah.
Okay.
So the first line treatment. So we already mentioned this, so I'm not sure I'm doing a good job if some of you answered entecavir. Entecavir is one of the treatments. However, any of the above can be given. All right. As I said, TAF is usually left for osteoporosis and patients with renal impairment, but any of the entecavir, tenofovir, alafenamide, TAF, or tenofovir disoproxil, fumarate, TDF can be used, okay? All right. Okay, I'll answer the rest of them after the end of the presentation, okay?
Okay, that's fine.
I'll stop sharing here. Okay. So special populations. If you want to talk, we already mentioned part of the special population. So we said that you treat co-infection, C, HIV, and D. We said you treat cirrhotic patients. We said you treat patients who are on immunosuppressive therapy. Okay, but I wanted to speak more about pregnant ladies, for example, which is a big problem in our part. So pregnant ladies, all pregnant ladies need to be screened, and they have to be screened in their antenatal visits early during pregnancy. Why? Because if you screen them early, you are aware if they are negative to vaccinate, or if they are positive to consider treatment. Okay, so screening them the day before they deliver is not a good idea. So they should be screened early during the antenatal care. And women who are negative, they need to be vaccinated. This is again a very, some people think that vaccination is even doctors, gynecologists and obstetricians think that vaccination is contraindicated. Actually, no. you can vaccinate pregnant ladies and it's safe at any time during pregnancy. And all B positive pregnant ladies should be considered for treatment. You look, do the history, check them clinically, see if they have fibrosis. It was initially the fibroscan was not validated for pregnant ladies, but it's okay to do now. APRI score may not be very helpful, but you can do transient elastography or fibroscan, or even if you clinically think they have any evidence of liver cirrhosis, you should treat. And that's for their own health. It's not only for mother-child, preventing mother-child transmission. As I mentioned before, entecavir is a category C, so you need to avoid entecavir in pregnant ladies, and the drug of choice is tenofovir. If by clinical assessment, she's already cirrhotic with hepatitis B infection, pregnant, you need to exclude varices, and that should be in the second trimester. And that why? Because if once the pregnancy increases, the risk of bleeding increases because of the pressure. So if you find a pregnant lady who is B positive having liver cirrhosis, you need to exclude varices in the second trimester. And if there are varices, you may need to do prophylactic bag ligation. Okay. Beta blockers can be used and they are not contraindicated in people who have in ladies who are cirrhotic, but you have to monitor, of course, the baby for bradycardia. It's important, as I mentioned before, to prevent mother-to-child transmission. So that's why there is a big movement to try to start hepatitis B vaccine at birth dose. So we do have hepatitis B vaccine, but unfortunately the vaccine we have starts on day 40 after delivery, which will not prevent mother-child transmission if the mother is E positive or DNA high. So the ideal is for the baby to have the birth dose hepatitis B vaccine, and it's 10 microgram. And after receiving the birth dose, then they go on to receive the usual 3 doses that are part of the EPI program. If the mother is E positive, they also need hepatitis B immunoglobulin, because E positive, the risk of transmission is higher. DNA high, the risk of transmission is higher, okay? And it's better to recheck the baby if they're positive or not after 1 year or 1 year and a half. The guidelines generally say if you can check for the viral load and the viral load is high or the mother is E positive, you should put the mother on treatment. So these pregnant ladies would require treatment even if there is no indication to treat personally. But of course, now with the guidelines, if the DNA is high, you would treat anyway. But if the mother is E positive, even if you don't have access to DNA, it's better to put them on tenofovir. This will decrease DNA and prevent transmission. Breastfeeding is not contraindicated. So if you have a mother who is B positive, she can breastfeed her baby. The baby should have received the vaccine, and she should only stop breastfeeding if she has cracked nipples or bleeding. Again, the mode of delivery does not affect transmission, and it should be only according to obstetric indication. So if there is an obstetric indication for C-section, yes, but if not, then normal delivery. Okay, children, put in mind that children who have B infection could be asymptomatic. Their immunity is used to the virus, so there is no symptoms, okay? Unless they are prone to biting or hitting or injury, they should not be banned from schools or camps or day centers. And we see this a lot according to social stigma. A lot of children who are positive, they are not allowed into schools, which is wrong. If the child has any evidence of liver inflammation, meaning high ALT or evidence of cirrhosis or fibrosis, they should be treated. And tenofovir and entecavir are licensed for children 2 years and older. It depends on their weight, and there are calculations according to weight. TAF is only indicated if they are 12 years of age. So less than 2 years, it's a problem, but 2 years and more, you can treat. For D, ideally, all hepatitis B patients should be screened for D. D is a virus that only causes problems in the presence of B. It can be a co-infection, so you can get both together, or it can be a super infection, meaning a patient who has B and then he gets D infection. And the co-infection with D virus causes more progression of liver disease, higher risk of liver cirrhosis and HCC. And it's a difficult virus to treat. We diagnose it by checking anti-hepatitis D antibodies. And if it's positive, we need to do RNA. I know that we struggled even in Khartoum to do sometimes RNA levels. But when we got the RNA level and the patient is D positive, these patients need treatment. And the treatment for a long time was PEG interferon, and that's for 48 weeks, so 2 years. And it's not a really nice medication, a lot of side effects. It's injectable, not really good response. But now there are new drugs coming out. One of them has been approved. I don't think it's available everywhere. Patients with renal disease, as someone asked, the best is any patient who has risk for renal impairment, like, for example, diabetics, hypertensive, people who have risk of having any renal impairment should be screened early. And if they are negative, should be vaccinated early. Why? Because once their renal function deteriorates or they start hemodialysis, the response to the vaccine is really poor. And people on hemodialysis, if you want to vaccinate them, you need to give them double dose. So instead of one, you give them double the dose, the normal dose of vaccine. Okay? If they are positive, although I don't think Hailey is here, but I don't think it was mentioned as part of people with chronic liver disease, but I would expect that people who have renal impairment, who have hepatitis B positive, you again do the full workup, similar to anyone else. If they have any eligibility, if they are, for example, C positive, HIV positive, or they have fibrosis, or they have persistent high ALT, or they have family history of liver disease, or other, or they are going for a transplant, for example, these patients need to be on treatment. If you can check DNA and it's more than 2,000, you treat. If they have significant fibrosis, you treat. Patients who are not eligible for treatment, then you need to monitor very closely because they are ill patients, they have comorbidities, and they can progress to liver cirrhosis. And treatment is, you can treat by entecavir, tenofovir, but according to the creatinine clearance. And if you read the guidelines, WHO guidelines, there are tables which shows you what dose to give according to the eGFR or the creatinine clearance. What about health personnel? Health personnel should be screened. And if they are negative, should be vaccinated, okay? And not only vaccinate, you should, if possible, check your antibody levels. And if the antibody level is above 100, you're safe, okay? Less than 100, you need a booster dose. Less than 10, you're not safe, you need full vaccination. But if you are positive and you do exposure-prone procedures like surgeons, dentists, gynecologists, phlebotomists who take blood samples, and they have detectable DNA, they will be for treatment to get their DNA low so that they are not at risk of transmitting the infection to their patients. The last one I wanted to talk about was management of acute hepatitis B. So as a place where we have a lot of hepatitis B, you can easily develop an acute hepatitis B. Acute hepatitis B means patient who was negative, had, for example, a needle stick injury or whatever, and got an acute hepatitis, meaning symptomatic, jaundiced, vomiting, epigastric pain, high liver enzymes. You suspect hepatitis B, you need to do the surface antigen and the core IgM. So it's the IgM that says that this patient is acute. And if this patient is acute, 95% or more of adults who are immune competent usually clear the infection and develop immunity. You don't need to treat them. You only consider treating them if they are going into fulminant hepatic failure or severe hepatitis. And we judge this by checking the serum bilirubin, checking if they are developing encephalopathy, their INR is getting higher. So that means they are going into a liver failure. And here, some people start treatment, and treatment can help them and can help the liver recover. This is important in our part of the world because these patients probably should be assessed for liver transplant. Unfortunately, this is not accessible in our parts easily. So this is something you can try, which can help the patient. And of course, you can treat with any, even lamivudine, if it's available, can be used, because usually treatment is short for 3 to 6 months after they clear the virus. If they don't, then you need to change to entecavir or tenofovir. And that's all I wanted to say today. Thank you.